Hi, everyone. Welcome. Just a few minutes until we get started, but I wanted to say hello and acknowledge people as they were coming in. I'm so excited for today's presentation. I think you guys are going to like it. Also, before we get started, I just wanted to quickly check in with our diverse OT chapters because I know you will all be introducing yourselves here. So I see that Milwaukee is present. Is anyone from our Madison chapter here present to introduce their e-board and what's happening?
Yes.
Perfect. And Boston University? I'm taking that as a not yet. Anyone from Colorado State University here? Taking that as a not yet. And then UW La Crosse.
Hi, I'm here.
Okay, perfect. So we're 3 for 5 at the moment. We'll give everyone a few more minutes and then we will get started. Okay, like I said before, welcome everyone. This is Diversity National's first ever general body meeting. So we're so excited to see everyone here today and get some learning in. So today's presentation is the Neuroscience of Injustice. And I think we will have a lot to reflect on. So this is our agenda for today. First, I will introduce our national board and our national organization for those who are not familiar with us. Then the second, we will have our chapters go around and they will give about a 3 to 4 minute presentation each, talking about their chapters and what they're up to. Then we'll go over our community agreements for today, and then we'll dive into the neuroscience of injustice. Last, I'll hang back at the end of the session. If people have any questions for me or just want to continue to talk, I will stay back behind, but I do want to respect everyone's time, so we will keep it to the hour and a half that we have allotted for today. So here we go. So Diverse OT National is an organization created by licensed occupational therapists, myself and Caitlin Roten. Diverse OT is dedicated to enhancing the field of occupational therapy by providing opportunities to integrate equity and cultural responsiveness into the occupational therapy student experience and develop and support the recruitment of underrepresented students into occupational therapy programs through community outreach and mentoring. Our mission is to advance the cultural climate within the occupational therapy profession. We strive to foster a strong community of critically reflexive occupational therapists and students equipped with the knowledge and skills to provide culturally relevant care to individuals, populations, and the communities that they serve. As client populations continue to become increasingly diverse, culturally responsive practitioners are essential. Occupational therapists must practice with cultural humility and continuously analyze how sociocultural assumptions, social positions, and biases intersect with client choices and freedoms. To accomplish this mission, Diverse OT strives to recruit and retain underrepresented students into occupational therapy students, increase occupational therapists and students' knowledge of culturally responsive concepts and how to navigate crucial conversations with colleagues or classmates, emphasize the importance of reflection of the larger picture to promote awareness of how we operate within a system, and to create affirming work or learning environments in which all people are free to express themselves and are provided with equal access and fair treatment. We envision a field of future occupational therapists who practice with cultural responsiveness and integrate principles of equity and inclusion in all they do. And our work is guided and informed by our beliefs and commitments to advocacy. We strive to influence decisions within political, economic, and social institutions. Empowerment, we are committed to empowering the new generation of occupational therapists and the communities that we serve. Culturally relevant care, we respect individuals, communities, and populations. We value diversity and are committed to equity. Occupational justice, we believe that all individuals have the right to participate in diverse and meaningful occupations. And community partnerships, we are committed to a culture of teamwork and collaboration. So this is our national board. Sorry, Dina, sorry, Fred. This is an old picture before they joined. But essentially here at the national board, we collaborate with our Diverse OT chapters. We provide consultation services related to justice, equity, diversity, and inclusion. We develop presentations and educational resources for our larger OT population and for our chapters. And what's in the works for our chapters, we are working hard on our mentorship program and community action committees, which will be a really big announcement for our chapters later. We're looking forward to it. So to introduce our board, we'll start with myself. My name is Tony. I am the co-founder and chair of DiverseOT National. I am currently a clinical assistant professor at the University of Wisconsin in Milwaukee. And my clinical specialty areas are neuropsych, cognition, mental health, and community-based practice. Then we have Caitlin Roten. She is our co-founder and vice chair. She'll be a little late to this meeting. She is the fieldwork coordinator and clinical assistant professor at the University of Wisconsin at Madison. And her clinical area is pediatrics and school-based OT.
Hi, my name is Monica Ayala. I am an OT working in the Milwaukee area. I work at the Milwaukee VA Hospital in mental health.
Thank you, Monica. And next we have Katie.
Hi, everyone. My name is Katie Conrad. I am a DiverseOT National Board member. Super excited for our first meeting. I currently work in the Milwaukee area as well. I work at a level 1 trauma center in acute care. I work mostly with patients in oncology, but also ortho trauma and vascular plastics. Yeah, and I'm very excited to be here. Thanks.
Thank you, Katie. Dina.
Hello, everyone. My name is Dina, newest board member, recent grad from CSU, and currently in the pediatric outpatient world and loving it. Glad to be here and welcome everyone.
Thank you, Dina. I love the energy. And Fred.
Hey, y'all. I don't have my face on, so forgive me. I'm excited to be here. I am creative. I make art. I do the social media posts and emails and all those kind of fun things. So yeah, I'm just glad to be here. Happy to learn. Yeah.
Thank you. And so yes, that's our national board. So now you know us a little bit. Next, I'd like to kick it over to our chapters so they can introduce themselves. I will, so we have 5 chapters. Our chapters are at Boston University, Colorado State University, and then the University of Wisconsin at La Crosse, Madison, and Milwaukee. So I will stop sharing because I know some of our chapters have their own presentations, and we will start, we'll go in alphabetical order and see who's here. So Boston University, are y'all here and ready to talk about your chapter?
Hi. Yes. So I do not have a presentation. Hello, everyone. My name is Shanice. I'm the president of DiverseOT at Boston University. Our other e-board members are Tori, who is our vice president, Daria, who is our secretary, Saul, who is our treasurer, and Yunjin, who is our community outreach coordinator. Some of the projects that we have been working on this year, we have started like bi-monthly coffee hour where different persons in the department from different years, so for years 1 and years 2, and if a year 3 is around, they can join too. We come and we chat about different topics, so we just have a chance to get to know each other. We also some things we have coming up is a financial management workshop for persons learning how to manage their finances post their occupational therapy program. And we'll also be having a Narcan and harm reduction training, just looking at our roles as persons who are responsible healthcare professionals. And then some other things that we have done, it's just like partnering with our community. We welcomed our OT Class 1 with another student organization that is in OT. And yeah, we've just been like finding different ways to like create community in our department. So happy to be here.
Awesome. Thank you so much, Shanice, for that great introduction. Boston University was our very first chapter outside of our Madison chapter. So they were really there in the ground with us trying to get this organization up and running nationally. So we love to see it, love to see you all still going strong. Thank you. Next is Colorado State University. Okay, I don't know if they have anyone here yet. That's okay. We'll go over to UW La Crosse. Is anyone here to present on behalf of your chapter?
Hi, Tony. Hi, everyone. My name is Miney, and I am one of the two co-presidents for Diverse OT. I'll just go down the list of our exec board members. Riley is the other OT, and then we have Alyssa as the professional development coordinator, Emma, the community outreach coordinator, Amanda is the secretary, and then Alyssa as well for treasurer. And right now, since this is our first year, we have been trying to just get into the groove of recruitment. So since the beginning of the semester, we've had 3 consistent first years who also joined us. They've solidified their positions, but in the semester, they've just been like shadowing. So Christy, Allie, and Allison. I don't think anyone else is here, but Christy will be the co-president. Allison is the other co-president, and then Allison, I believe, these are just decided yesterday, so it's still fresh in my mind. Excuse me. Let me just pull it up. So then Allie is the community outreach coordinator. And yesterday we celebrated our first year as becoming an official org, so that was super exciting. Some events we've had since this past year are like fundraising. We had a Become a Dementia Friend, a discussion with the LGBTQ ally organization on campus here, and outreach to undergraduate students, Occupational Therapy 101, where we kind of gave them a tour of the ADL room that we have on campus, and then just kind of a get to know you casual stress ball making. So that was a lot of fun. This past month, we had 2 events, like the Hmong culture and healthcare in collaboration with SODA, as well as a criminal justice lecture with Dr. Lisa Cruz. So that was super exciting. And to finish off the semester, we plan on having a t-shirt fundraiser that's in its final stages. So I'm super excited for that. And we will also be having another lecture by Dr. Marcus Lewis, who is a member of the Whole Chunk Nation, and he'll just kind of give us more information about inclusive language. So yeah, that's us.
Awesome. Congrats on the 1-year anniversary and great work, Mimi. Thank you. Next is UW Madison.
Hi, my name is Katie. I'm one of the co-presidents, and I think Becca is going to share her screen with our little presentation.
Hello. I will. All right, it's only letting me share my entire screen, so bear with me for a second while you all see your own faces.
Right.
Can you all see this? Okay, perfect.
Good to go. As I said, my name is Katie. I'm one of the co-presidents alongside Becca. Some of our other e-board members, I'm not sure who's all on the meeting today, but we have Alyssa and Mary. They work together on community outreach. And then we have Claire as our professional development coordinator, Emily as our secretary and social media coordinator, Brooke as our treasurer, and then Maddie, she's an undergraduate liaison, so she's our one undergrad on the e-board.
And then for the projects that we've been working on this semester, we're working to reestablish our presence on campus. We sort of fell off a little bit during COVID, and since then we've slowly been trying to build our organization back up. It's been really exciting to see how many undergraduate students that we've got participating this year, and even freshmen coming along ready to become future OTs, which has really been a cool experience. We are also working on developing partnerships with other student organizations. So right now we have a partnership that we're working on with the Student OT Association, our SODA board, and then also an undergraduate mentorship program called Connect within our kinesiology department. And then we're looking to see if there are any avenues to expand from there. We also host annual application nights every fall around the time when the application to our program is due. And it's been cool to see students who are even like a few years away from applying, attending now to see how they can better prepare themselves for applying in the future. We've also started working with our program director and our admissions coordinator on what it would take to set up a scholarship through DiverseOT to waive program application fees for individuals applying from underrepresented backgrounds, either to our program or just seeing if we can set up something through OTCAS. And then we've also been struggling with getting back into high schools post-COVID. But recently, an alumni of our program that works in the Diversity, Equity, and Inclusion Committee in the Madison Metro School District's PT and OT department has reached out, and they're talking with their admin board about setting up a partnership with us. So that's really cool.
And then,
yeah, go ahead.
then this slide just highlights some of the speakers we've had this past year. Starting in October, we had Dr. Roten actually come lead us through a workshop on exploring identities, and that was a really good conversation for a lot of us and a lot of the undergrad students. And in November, we had Catherine Briggs come talk about healthcare professionals and how they can affirm LGBTQ+ clients. In February, we had Dr. Mark Loden discuss healthcare in the Amish community here in Wisconsin and the greater United States. A couple weeks ago, we had Miso Kwak come talk, give a presentation about healthcare professionals through the lens of disability. Yesterday, we had a meeting with Denise Johnson, and she just talked about effective communication skills for individuals who are deaf, deafblind, and hard of hearing. And then our last meeting of the semester will be with Dr. Alyssa Ramirez Steg and May Ramirez, just talking about culturally affirming care with disabled Latinas. So I also just want to mention, I'm going to drop my email in the chat if any of you all are going to AOTA next week, and I would love to do a little DiverseOT meetup.
I would also love for that to happen, and we'll be at AOTA. So yeah, let's touch in on that and make that happen. I love to hear everything that's going on at UW-Madison. Very proud of you all. I am a little biased. That is our flagship chapter, established in 2016. So it's great to see you all thriving all these years later. And we're very proud of you for getting the chapter back, not only after COVID, but after the transition from MS to OTD. So there's been a lot of great work coming out of Madison. Great job, y'all. And last but not least, UW-Milwaukee.
Hi, everybody.
Are we
sure? Yes. Okay, hi everybody. So we are the Milwaukee chapter. I'm one of the co-presidents, Sarah. I'm the other co-president, Madeline. We're just going to kind of talk through our e-board and kind of the same process. So DiverseOT Milwaukee chapter executive board. Okay, that's us. So basically, what Madeline and I are in charge of, we're basically doing facilitating meetings and events and like communicating with student orgs and advisors, and then with the general and executive board meeting follow-ups and everything. Okay, so these are just our faculty advisors specifically for like our chapter. So we have Tony, obviously lovely Tony, and then obviously the lovely Tamika Galtine. So they kind of just help us stay organized, give us more ideas for events, for activities that we do for both the e-board and the general board. So they have been super helpful and patient and, you know, willing to teach us new things on like leadership and how to like run meetings and stuff, because we've had maybe a few few meetings before the second years kind of passed the role down to us. So a lot of, again, we're still learning on certain events and how to run these activities. So they've been super helpful.
So our community outreach coordinators are Jordan and Asha. They're basically in charge of partnering with the community and organizations to learn about and support the needs of our greater Milwaukee community and promote diversity in healthcare through organized events.
All right, and then we have our secretary and social media chairs. So Allie and Marissa, they kind of share these roles together. So they often collaborate with one another, just like me and Sarah. Their roles are usually to like record meeting minutes, manage social media pages. Here's a list of all our social media. You guys wanted to take a follow, we love that. And then obviously we update like when we're having meetings and events, they will share it usually 2 weeks or in advance to see, if we can get undergrad to participate or staff and faculty.
And our undergraduate liaisons is Hannah and Carly, and they're basically in charge of maintaining contact with the undergraduates, and letting them know like when we have meetings and stuff, letting them be part of not only just graduate school, so having them involved into it too.
All right, and these are professional development coordinators. So we have Kelsey and Stephanie, and they essentially work on campus and off campus to kind of look for like groups for like host speakers, talking about social justice issues and underrepresented groups. And they also will be developing opportunities for the MSOT students to also like lead sessions and talks with underrepresented students, just kind of facilitate that interaction.
And then our treasurer is Jackie, and she's in charge of like keeping track of the funds and expenses of the organization. So.
Okay, and then this is just like kind of a brief overview of our goals, some events we've done, and just kind of a vision for our chapter. So one is to advance the cultural climate within UW Milwaukee, OT program, facilitate events, discussions, educate the community, and obviously promote equity, inclusion, and diversity. So that's been kind of a running definition or stance that almost all the chapters probably have. So some events we did do a race to dinner event, which is, event loosely. We did talk about, there's this documentary called Deconstructing Karen, and it kind of went through a lot of racial discussions between like white supremacy, racism, just like, inter-racism just between minorities even. And we just kind of all gathered and had that discussion and just kind of look at our own biases and like stereotypes that we may inherently have, or we see like, outside in the world, in our program, in our community, so on and so forth. And then we also had guest speakers from the Dominican Center, and they kind of came in and shared about I'm going to pronounce it wrong,
Amani neighborhood.
Amani neighborhood, and they just kind of do community outreach with that population, and they kind of shared their experience and how they are able to like kind of give back. And then another one of our values is just to be a community for people of color, minorities, and like allies to gather and share thoughts, experiences, and educate one another in the academic setting. So a lot of our meetings have been pretty kind of like low-key, in a way like a safe space. So for people just to kind of gather to take a break from life, like jobs, school, like everyone's busy, but we have become more of a safe space where we can have conversations and just kind of, be together and kind of have that interaction with one another. And then last, we want to facilitate systemic changes pertaining to race, sex, gender, identity, religious practice, and culture within our MSOT program. So me and Sarah, along with Tony and Tamika, we were all just trying to like, for future events, kind of promote all of these elements. And we do have one discussion coming up that Tony actually kind of led, that we will be discussing in our next meeting next Monday, and it's gonna be about cultural humility versus cultural competence. And so that will be like kind of our like last meeting where we'll have that discussion. We're going to talk about just kind of what plays into that role, and then maybe plan for other like social events for the end of semester. So yeah.
Thank you.
Great job, y'all. Okay, so I am biased because those are my students and I'm just very proud. So that was very great work. Thank you, Madeline and Sarah, and thank you, UW Milwaukee. So those are our chapters. That is what we're up to. And it's also really cool to just see the power of students. I am very amazed by all of you, and the work that you all do really inspires me to continue to do and be the best that I can be. So I really do appreciate it. And I'm honestly very humbled that there are 5 chapters of Diverse OT. So that's really cool to see. So thank you all so much. And let's get into today's, I don't want to say lecture, it's more of a conversation called the Neuroscience of Injustice. So it will be a discussion. I'll have several points throughout this presentation for us to stop, chat, and reflect as a group. You can either raise your hand to say something, or I will also be able to monitor answers that are coming through the chat. So however you feel most comfortable communicating, that is cool with me. So let me pull this presentation back up and we'll get started. Oops. Okay. All right. So just before we get started, I wanted to go over some community agreements for us. The first is to speak from the I perspective. Avoid speaking for others by using we, us, or them. The next is to listen actively, listen to understand, not to respond. Sometimes we are tempted to start formulating our response. Instead, let's give 100% of our focus to whomever is speaking. The next is step up, step back. If you're someone who you usually speak often or finding yourself talking more than others, challenge yourself to lean into listening and opening space for others. And if you're someone who doesn't talk as much in groups, we would love to know what you're thinking and challenge you to come forward with your voice. The next is to respect silence. Don't force yourself to fill silence. Silence can be an indication of thought and process. Share, even if you don't have the right words. Suspend judgment and allow others to be unpolished in their speaking. If you are unsure of their meaning, then ask for clarification. The next is to uphold confidentiality. Treat the honesty of others as a gift. Assume that personal identities, experiences, and perspectives shared in this space are confidential unless you are given permission to use them. And the last is to lean into discomfort. Learning happens on the edge of our comfort zones. Push yourself to be open to new ideas and experiences, even if they initially seem uncomfortable to you. So if everyone could just give me a thumbs up if you're down with the community agreements, raise your hand if you have any questions, or if you have any agreements you would like to add, drop them in the chat. But if you can give me a thumbs up emoji reaction, then I'll know that we're all agreeing. Beautiful. Love to see it. Love to see it. Okay. Seeing plenty of thumbs up. I love that. Thank you so much for agreeing. And then our boundaries and expectations for today. This is an anti-racist learning space. So that means there will be a zero tolerance policy for racism, sexism, classism, ableism, transphobia, homophobia, xenophobia, Islamophobia, anti-Semitism, and hate speech or actions that attempt to silence, threaten, or degrade others. Here in this learning space, we should uphold the community agreements and engage in mutual respect. And last, we should respect diverse styles of expression. So respect different styles for presenting, respect different lived experiences and viewpoints, and respect different ways of knowing and being. So can I get another thumbs up if we're cool with these boundaries and expectations? Hand up if you have a question, or drop something in the chat if you would like to add something. Okay, awesome. Seeing lots of thumbs up reactions. Thumbs up, thumbs up. Thank you. Thank you so much, everyone. All right, then let's get started. I'm really excited to get this conversation started. So we will start with the neural basis of adaptation, which is neuroplasticity. So what is neuroplasticity? Neuroplasticity is a lifelong default plastic capacity that allows changes in the brain's function and structure in response to environmental demands. So simply put, neuroplasticity is the ability of the brain to form and reorganize synaptic connections, especially in response to learning, experience, or following an injury. So it allows our brain to rewire. This capacity underlies development and learning and allows rapid adaptation to the environment. Our default plasticity decays with aging, and additionally, there is an increased slope in this decay that can result from illness or damage to the brain. So that just means that our neuroplastic capacity slows down as we age. The slowing of our neuroplastic capacity is accelerated via illnesses such as Parkinson's, dementia, Alzheimer's, mild cognitive impairment, or damage to the brain, something like a traumatic brain injury, a stroke, or some other illness that is impacting the brain. So this is neuroplasticity, what it is, and how it is impacted. So there are 4 different types of neuroplasticity. Our developmental plasticity is also known as our critical period in early development. So in early development, neurons are created in overabundance, and then the glial cells are increased in development, but then we go through something called the synaptic pruning to clean up the connections that we're not really using. The next is synaptic plasticity. So synaptic plasticity involves changes in the strength of connections between individual neurons and the formation of new connections between neurons that result in changes in the wiring of the brain. So our synaptic plasticity is important for learning and memory within the hippocampus. Next, we have homosynaptic plasticity. So there, homosynaptic plasticity produces changes in communication at the synapse that were directly activated at the time of information transfer. What's important to know about homosynaptic plasticity is that it helps to regulate excitatory and inhibitory inputs, and it's also important for creating homeostasis that leads to an optimal environment for learning. And then last, we have heterosynaptic plasticity, which produces changes at synapse that were not active during the information transfer. So our heterosynaptic plasticity is important because it contributes to a variety of neural processes, including associative learning, the development of neural circuits, and the homeostasis of synaptic input. So it is important to know that our neuroplastic ability is something that goes from the developmental plasticity, from development through our entire lives. So our brains are constantly changing in response to the environment around us, to the inputs throughout us. And these changes occur at multiple levels. So neuroplasticity and occupations. So our brains change in response to engagement in occupation. Occupations, for our non-OT friends, because I know some of you on here are not OTs, are activities that we engage in. So they can be basic, such as brushing our teeth, washing our face, getting dressed, or more complex, like banking, cooking, playing an instrument, reading books, going for a run, socializing, knitting, dancing. Basically, anything you do is an occupation, because I will be using the word occupation and activity interchangeably throughout this presentation. Engagement in occupation can be used to drive neuroplasticity to enhance recovery of function in the cases of injury or disease process. And here, and we'll know that the changes occur at the level of the synapse, resulting in the strengthening or weakening of synaptic connectivity, as well as at the representational modular level, resulting in changes in communication patterns between neural networks. The stronger our synaptic capacity, the more efficient our processing skills. And even when we repetitively imagine engaging in occupation, so even the thought of doing an activity. So close your eyes right now and pretend that you are folding laundry. Just go ahead and do that. Guess what? Your brain is engaging right now just by you closing your eyes and thinking about folding your laundry, and the brain changes in response to that engagement. So it's really important here because practice and novelty are important elements that drive plasticity in the human motor system. And what we mean by novelty, that just means engaging in an activity that is new to you or something that you don't typically do. So to sum it all up, occupational engagement promotes neuroplastic change and recovery of function. So this is our first pit stop for some reflection questions. And again, please feel free to raise your hand if you'd like to respond, or you can drop your responses in the chat. So our first question that I have for the group is, if we know engagement in occupations drive neuroplastic change, and our neuroplastic change helps to protect us against different neurological disorders, we know that it's really important to engage in occupation then. So the next question I have for the group is, what are populations in society that are prevented from participating in meaningful occupations? Who are people who are groups or people who are prevented from doing the things that they want to do? Geriatric population, I have incarcerated individuals, Black, Indigenous, and people of color, individuals who are incarcerated, individuals experiencing marginalization, individuals who are in forced labor or human trafficking. We've got disabled individuals, unhoused individuals, refugees. Okay, so at this point, I'm feeling like you all got the presentation ahead of time because yes, those are exactly some of the populations. So the populations I have listed here are not an exhaustive list. It's just an example of populations who are prevented from participating in meaningful occupations. So then our next question, right, is how and why are they prevented from participating? Why are these populations at risk from not being able to do meaningful occupations? When you're locked up, you're being controlled. Absolutely, absolutely. You don't get to pick and choose when you want to do something. Veronica, systemic barriers, absolutely. Valencia, struggling to meet the basic necessities to live, no support or resources, or what they do is societally not accepted. Thank you so much for touching on that point, Valencia, because that is a big barrier as well. It's not just some of the systemic barriers, but also those social barriers of some occupations are seen as unacceptable in society, but they're still the occupations that promote survival or living. We also have Amy, who said they do not have equitable access to the resources needed to engage in occupations. Absolutely. Institutional discrimination. And Lauren has social stigma, having to prioritize meeting immediate needs prior to desired occupations. So again, you all have hit the nail on the head. So looking at our legal system with our incarcerated individuals and psychiatrically incarcerated individuals, because those are two intertwined systems, our incarceration system and our psychiatric hospitals. And psychiatric forensic facilities. In those facilities, people are locked up. There are some people who are incarcerated right now who spend 23 hours per day in solitary confinement, and they're given 1 hour a day to walk around, right? So that would be a terrible situation. And this is someone who's prevented from engaging in occupations. Just as Valencia hit on before, the societal stigma. Sometimes there are some people who have engaged in occupations that are not seen as acceptable in society. So people are not able to as easily do them or are in fear of that social stigma. That also goes with the fear of being arrested, fear of getting in trouble, fear that you'll be rejected, fear that you will lose your benefits, fear that someone won't believe that you're actually disabled. There are a lot of things that prevent people from participating. And then I believe it was Veronica earlier who said systemic barriers. So race, class, gender, SES, ability, and our religion could all be things that are preventing us. So if you are a person who really wants to play the piano, what does it take to be able to play the piano? If you said, I want to be a piano player, let me know in the chat. What does it take to be able to play the piano? Monica, fine motor skills, look at our OT. It takes money, it takes finances, because it takes free time. It takes a love of music. Thank you, Dad. Yeah, so if you want to learn how to play the piano, you would have to have access to a piano. I don't know about you, but pianos are very, very, very expensive. So do you have a music store or a music library in your community to be able to go play a piano if there's not one available in your community? Is there a piano teacher around where you are? Can you afford a piano teacher? Can you afford to learn how to read music? Do you have access to music programs within your school system? Things like that. So think about that for every single occupation that we engage in. There are things that make engaging in these activities possible. And sometimes these are the barriers that we can overlook as practitioners, but these are the barriers that are very present. So thank you, everyone. So now we will look at our neuroplasticity in relation to cognitive performance. So our cognitive capacity is related to flexibility allowed by our default plasticity. These concepts are grouped as fluid intelligence. There are certain circumstances will push the limits of our default plastic capacity, leading to increased efficiency in cognitive processing, i.e. better working memory, improved executive functions, and faster processing speeds. I'm going to put my students on the spot. I would like y'all to drop in the chat, what are our executive functions? Because every people here who don't know what those are might not know why they're so important. Working memory, nice. What else is part of our executive function? Decision-making, initiating, planning, excellent, Asha. Great job, Allie. Great job, Carly. 5 imaginary bonus points to you for neuro. Yeah, so our certain circumstances will push the limits of our default plastic capacity, leading to increased efficiency in cognitive processing, like I said. And these are better working memory and improved executive functions. As you can see, the students from UW-Milwaukee are putting in the chat right now what our executive functions are. It's initiation, planning, decision-making. It's being able to self-monitor, so insight to self. And it's what essentially allows us to be able to get up and function. And that's why we call them our executive functions. And as we see, direct measures of brain plasticity and the potential for experience-dependent cortical alteration have been shown to decrease with age. So this just means that our cognitive functions slow down as we age. And something to know here as well is that a big takeaway from this slide is that the more plastic your brain is, the more efficient your cognitive performance will be. So we have to look at some of our social determinants of our brain health. So we know engaging in occupations are important for plasticity. We know that life experiences have a big influence on our neuroplasticity and our brain development. So let's see about what are some social factors that impact our brains, our functioning, and how we can do. So to a certain extent, our genetic factors determine the baseline of our default plasticity, whereas our experience in the world contribute to either reducing or increasing the slope of decay. So based off of your experiences in the world, your default capacity can either decrease really rapidly or decrease faster than typically, or based off of your experiences in the world, you can build up your cognitive reserve, so then it will slow down the process of that cognitive decay that we talked about in the previous slide. Our changes in health and well-being as a result of trauma or prolonged exposure to stressors, biological or psychological, critically affect neural networks and their adaptability. So any type of prolonged stress or trauma is going to impact our neural networks and their ability to adapt and change, AKA our plasticity. So it's going to critically affect our neuroplasticity. Neuroplastic changes reflect a person's cognitive resources for occupational adaptation and their ability to cope with adversity or trauma, which influences the recovery process. So, for example, there's epidemiologic evidence that shows that people with a higher level of education have a lower risk of Alzheimer's disease, right? So that's going to be a social determinant of health. Then we see that more about our cognitive reserve. So cognitive reserve refers to individual differences in how tasks are performed, and that may allow some people to be more resilient than others. So you can think of cognitive reserve as your brain's ability to improvise and find alternate ways of getting a job done. That's what cognitive reserve is. Cognitive reserve reflects how agile your brain is in pulling in skills and capacities to solve problems and cope with challenges. Cognitive reserve is an active concept. This is because cognitive reserve is malleable or changeable and is influenced at every stage of life. So like I said, based off of our experiences in our world, whether positive or negative, this is going to impact our plasticity and impact our cognitive reserve. Our cognitive reserve is thought of as the software of the brain. And so essentially the higher reserve that you have, the better a person will do when there is damage to the brain. So I do this example with my students all the time. You can think of cognitive reserve as, if I'm someone with high cognitive reserve, let's pretend this is my reserve up here. So if I sustain a traumatic brain injury, via a car accident or something like that, and I sustain a lot of damage to my brain, it's going to knock down my cognitive reserve, and then it's going to impact the rest of my brain. So you can see someone with a higher reserve, you're going to see the reserve protecting them, and they're going to appear differently with their symptoms and their process or their prognosis for recovery versus someone who has a lower cognitive reserve and I have a traumatic brain injury, we're already right there. And so we're going to see worse outcomes there. Our cognitive reserve, the more reserve or software that you have, it essentially is the more resilience you have to handle changes to the brain. Some proxies that are used for cognitive reserve are IQ, which I would like to note that IQ testing and the history of IQ testing is based in eugenics. So I'm really not a fan of IQ testing, but it is used as a proxy. Proxies for cognitive reserve are also looking at people's level of education and literacy rates. So again, the higher the education level, the higher the literacy rate, it's going to be assumed that you have a higher level of cognitive reserve. Also, engagement in occupational attainment. And again, that's not just our jobs, but it's our ability to engage in new and challenging occupations or activities. So those novel tasks, those things that challenge us, those things that make us think, the more you're able to do that, the higher your cognitive reserve will be. And it's the same for leisure activities. The more that you're able to engage in your leisure activities, especially ones that are stimulating the brain, the higher your cognitive reserve will be. And that will therefore better protect you. And again, like I said before, a higher cognitive reserve is associated with a reduced risk of dementia, Alzheimer's, and mild cognitive impairment. And last, you'll see that mentally stimulating activities, years of education, and an active lifestyle seem to contribute toward cognitive reserve. And like we said, delaying the onset of dementia. And also in general, the best thing you can do for your brain is sleep and exercise. That's just like a side note for everyone. Even just like 15-minute walk around the block is going to be great for your brain. So then we will stop here at our next reflection point. What are the barriers to participating in activities that would improve cognitive reserve? What are the systemic barriers people are experiencing currently? So here we can see on the one column, we see the things that build our cognitive reserve, such as positive experiences in the world, mentally stimulating activities, and enjoying an active lifestyle. So these will be the things that build our reserve versus prolonged exposure to stressors, trauma. Those are going to be the categories of things that decrease our cognitive reserve. So I want us to talk together. We'll start with experiences in the world. What are some of the barriers to being able to have positive experiences in the world that promote cognitive reserve and neuroplastic function and brain function? Yes, so abuse, racism, chronic exposure to racial abuse, those are going to be some of the things that are prolonged exposures to stressors. I don't go for a walk in a neighborhood that is dangerous, lack of adequate nutrition. Yes, absolutely, I am loving these responses. So here to jog our memory a little bit and help us out. These are some of the ways in which people can be impacted in attempting to do the things that are healthy for their brain. So on the one hand, with experiences in the world, and we talked about it even with the piano example, how much does it cost? Is it accessible? Do I live in a community in which I even have this option, right? So we talk about things like being able to maybe go to an art museum is something that is an experience. Is there an art museum in your city? Are you able to get to that museum? Do you have to take the bus to get there? Are there buses running in your community? When you get to that art museum, are you someone who will be welcomed there? Or are you someone who, might experience issues once you're there? Those are the things that we have to think about. So looking at our experiences in the world, and some of those things are the same. Here, for mentally stimulating activities, let's, for a minute, just to shine something on our public school systems and our pediatric practitioners out there. What are some barriers when it comes to public school systems and having children engaging in mentally stimulating activities. What would we say could be some issues that we have in public schools that are systems issues? State policy. Yeah, I would love for people to take a look at what's happening in the state of Florida. They're actively removing books from schools. In the state of Missouri, they just voted to defund all public libraries, things like that. So their policy is impacting our public school systems and the ability to be able to do mentally stimulating activities. Yes, lack of resources. So when there's a lack of resources, that's why you see schools that are in, thank you, Jamie, schools that are in well-funded areas based off of either the socioeconomic status of the community. You're going to see programs that have art programs and dance programs and opportunities to go on really cool field trips. And then you'll look at school districts that are in underfunded school districts, and those students don't get those opportunities. They don't get to go on field trips. They don't have the dance team. They don't have the swim team and things like that. So that's where you're going to see a difference in the ability to be able to do mentally stimulating activities. Yes, Madeline. Also, gun violence. Gun violence is a huge going for all school children, and also the teachers and staff that are in those buildings, but that's going to be a huge stressor. And we actually have gun violence listed as a prolonged exposure to stressors, because this is the reality of children and teachers across America every day, is rehearsing lockdown drills and being scared that you're unsafe in your own school. So these are things that can really impact public school systems and children who are impacted by these systemic barriers, by unfair state policies, by living, just because you're born in a low SES community, why does that mean you shouldn't have what a child who is born in a high SES community? And those are the systemic issues that we have to address what's going on, because this has a huge impact on brain development, brain function. We also talked about active lifestyle being really helpful for your brain and great for brain development, cognitive reserve, and neuroplasticity. We also saw that these, I think it was Dr. Sholeru who put in here, that's my dad, not me, that maybe you don't live in a neighborhood that is safe enough to go outside. You also could worry about, is there a gym in your community? Are the sidewalks safe and accessible? If there is a rec center in your community, does it cost money? Can this person afford to go? So these are all really important questions. And then we have our general prolonged exposure to stressors, which are poverty, racism, homophobia, transphobia, gun violence, police brutality. And those were just some of these that I could think of. What are some other prolonged exposures to stressors that we could see? Drop it in the chat for me. Chronic illness. Exactly. And with chronic illness comes not only the illness, but the prolonged stressor of interacting with our for-profit healthcare system. We also have food insecurity, abuse of home, racism, pollution. Yes, pollution. Thank you for saying that. Substance use that has become harmful, and incarceration. Yes, these are all prolonged exposures to stressors. And then also we have trauma. So child and elder abuse, racial trauma, historical trauma. Historical trauma, to sum it up, is just trauma that has occurred to a population of people. So for example, the Japanese people being put in internment camps during World War II. That is a historical trauma to Japanese American people. Things such as slavery and Jim Crow, that is a historical trauma to Black American people. So that's what historical trauma is. Also exposure to violence. And our COVID-19 is actually an ongoing trauma that from the pandemic. People are sick, people are dying. We have people who don't have access to the healthcare that, that they need. And then we talk a lot about how the more neuroplastic your brain is, the more cognitive reserve you have, the more resilient your brain is going to be. But we also have to ask ourselves, who in this world is forced to be resilient? Because the thing about the stressors that we have listed here, these are systemic issues. So as I will use myself as an example. So as a Black person in America, day to day, am I saying that people run up to me and say, hey, you're Black and I don't like you? No, I'm not saying that is happening. But something that is happening is when I go into this world, will I be pulled over by the police? How will that encounter end? Will that end with me dying? If I have to go to the hospital for healthcare, I know that there is going to be a difference in my treatment based off of race. And this is all things that we talk about in our health programs, and we talk about health disparities ad nauseum. So we know it is true that people are treated differently based off of race in healthcare. It's also saying that when I am out and about, just in general, will I have to pay attention to what's happening in my state legislature? Are they trying to take away some of my fundamental rights? So that is something, even though day to day I might be having positive experience, because of those systemic injustices that are occurring, systemic racism, things like that, it is still having an impact on my brain because I have to pay attention to those stressors. I have to prepare for those stressors, and it is something that is acting upon me. So that is how our prolonged exposures to these systemic issues are impacting our brain. This is the neuroscience of injustice. This is why it's so important, because it is about our systems and how our systems are inequitable and how they are enacting on populations at all times. These systems are present at all times. So we want to go a bit more into the social determinants of health. So we know, like we said, exposure to prolonged stressful conditions. And as a reminder, here are these stressful conditions: poverty, racism, homophobia, transphobia, gun violence, police brutality, incarceration, food insecurity. What were the other ones that people said here in the chat? General abuse, trauma, our historical trauma, exposure to violence, all of these things that are happening, all of these prolonged exposures to stressful conditions during the critical periods. So while in childhood, just being exposed to these things can have a lifelong negative impact to the individual's occupational adaptation process. Executive function has been found to be mediated by a widely distributed and interconnected neural networks that include prefrontal areas and parietal cortex and subcortical structures. These neural systems are particularly vulnerable to environmental influences, including toxic stress and poverty. So essentially, early childhood exposure to stressors has been associated with increased prevalence of depression and mood and anxiety disorders in adolescence and adulthood. And we know that these prolonged exposures to stressors can impact our executive functions. And our executive functions are essential because it helps a person break out of routines and habits and focus on goals, prioritize, sequence activities, make decisions, evaluate risk, and plan for the future. So in short, our executive function is critical for decision-making. And when executive function is impaired, it can lead to either abnormal decision-making or a challenge in the decision-making process, and it can also just lead to challenges in functioning in our day-to-day lives. People who also struggle with executive function are some ADHDers. So if you're an ADHDer, this is what I'm talking about, our executive function. Our other social determinants of health, we have to talk about resilience. So resilience refers to the physiological and behavioral adaptation to stressors. From a physiological perspective, resilience refers to a mechanism that supports survival and well-being. So we know that resiliency is higher in people with higher cognitive reserves, with a higher cognitive reserve, the more resilient you will be. So if you're a person who, say you got that high cognitive reserve and you've got just these systems constantly acting on you, it's pushing your cognitive reserve down. And this is the same reserve that is supposed to help you with your resiliency. So you can see that it is just kind of a little bit of a losing battle here to be able to be resilient all the time, especially in populations that are exposed to this prolonged stress. And a lack of adaptation or a lack of resiliency can lead to increased vulnerability to hypertension, immunosuppression, osteoporosis, insulin resistance, truncal obesity, cardiovascular disease, anxiety, depression, depressive disorders, and post-traumatic stress disorder. So to put this one together, resiliency helps to protect you from all of these things, but resilience is based off of your level of cognitive reserve. If you're someone who is constantly experiencing prolonged trauma, you're someone whose cognitive reserve is going to be decaying at a faster rate. If that's happening, it can't protect you against not only your brain health, but your physical health. And if we look at this lack of adaptation, let's go through quickly these health conditions that are listed. So hypertension, if we look in health disparities, and drop it in the chat if we know it, I'm gonna call my brother out, I know he's here, what are the differences in diagnosis of hypertension? Who is more at risk for hypertension by population? Because the answer is going to be Black American people. We also see a higher rate because insulin resistance relates to diabetes. Diabetes is something where you're going to see a higher rate of diabetes in Black populations, in Latinx populations, and in our indigenous populations. The same goes for our obesity, cardiovascular disease. Everything that's listed here are all the things that if you looked at a health disparity chart by diagnosis of underrepresented populations being overrepresented in these various diagnoses, these are the ones that you're going to see. And this is related to, there are a lot of reasons why this is happening. It's not just because of cognitive reserve. I want to be clear about that, but this has a big part in this. Here you can see right here how health disparities are coming about. It's because again, I want to drive this point home. These prolonged stressors, these trauma, all of this is making people ill. Our systems are making people sick. So we also want to get into some of the brain structures that are impacted by prolonged stress. So our prefrontal cortex, which is in charge of executive functioning, it typically, like we said, it shuts down some of the executive functioning, and it also impacts impulse control, working memory, and cognitive flexibility. The neural structures that support executive functioning are the prefrontal cortex, as well as the anterior cingulate and amygdala. And these are all structures that are very vulnerable to toxic stress and poverty. So these brain structures are very vulnerable. We see with our amygdala, when someone is experiencing chronic stress, toxic stress, the amygdala is kind of our alarm that makes us say, what's in my environment? Am I okay? What's going on? And so with chronic toxic stress, the alarm is turned on but it never turns off. And when we have this constant running, your amygdala actually increases in size and has those running thoughts of, oh, I'm scared, I'm panicked. And also to anyone who has any anxiety disorder, your amygdala, that's what's happening. Also, our subcortical flight or fight areas, which includes the thalamus, hippocampus, brainstem, and hypothalamus. With a hippocampus, we see that it doesn't really develop well, and there will be a difficulty with learning and memory. In children, it might present as issues with like school problems and learning disabilities. So some of the most important consequences of developmental adversity are the result of abnormal development and functioning of the brain's stress response systems. So that is important to know for our PEDS people, but also how it impacts us into our adult years. Positive experiences increase the connectivity of our adaptive neural networks that promote positive emotions and actions. And epidemiological studies suggest that prenatal exposure to stress, such as the mother's depression or to excess glucocorticoids, increase the risk for low birth rate or small size at birth and is associated with neurophysiological changes in affecting the infant's ability to regulate stress. So this last bullet point here is the neuroscience and the neurological basis of the cycle of trauma. So essentially, our brain is particularly responsive to experiences and environments during early development, which influence how well or poorly its architecture matures and functions. So going back to those brain structures. Early experiences causes epigenetic adaptations in the brain that influence whether, when, and how genes build the capacity for future skills to develop. Modification of the epigenome caused by stress during fetal and child development affects how well or poorly we respond to stress as adults and can result in increased risk of disease, just like the diseases that I pointed out the slide before. Injurious experiences such as malnutrition, exposure to chemical toxins or drugs. So shout out to whoever said that our pollution and our current environmental situation is a toxic stressor. And toxic stress before birth or in early childhood are not forgotten, but are built into the architecture of the developing brain through the epigenome. So even things that someone could experience as an infant or in the womb that's happening to their parent, that is going to stay within your body remembers, and it goes throughout your entire epigenome. So this can affect multiple organ systems and increase the risk not only for poor physical and mental health outcomes, but also for impairments in future learning capacity and behavior. So this is really important to know. So that is our presentation, and I wanted to spend the last 15 minutes here. I wanted to spend some time asking some reflection questions, but also I've been to a lot of presentations like this where someone drops a lot of heavy information on me, and then it's like, oh, dang, well, that really sucks that there's nothing that I can do about it. And the last 15 minutes of this presentation will be talking about how we can address these systemic injustices. But I'd like to hear from you all first. So why is it important to recognize the impact of injustice on neurofunction? Yes, Dolly.
Hey, Tony.
Hey.
Awesome presentation. I feel like this question is so loaded. Like my community health brain just kind of like thinks about the community. But just to try to keep my answer very short, I work with inpatient neuro adults, and I feel like just in the hospital, primarily we're working with a medical model, and there's a bunch of issues with that. But I feel like as practitioners, we become so accustomed to look at neuro rehab as an individualistic responsibility. We put a lot of responsibility on the client. And, just from your presentation, we can obviously see that a lot of this, there's a lot of systemic things going on, right? In the environment, in the context, and that truly impacts someone's recovery, just what we know about motor control and the process, and neuro rehab in general. But, when someone leaves the hospital, and the research supports this, that any skills, transfers, all of that stuff, it just declines after, I think it was 9 months after someone has been in, hospitalized, and they learned all these great strategies and things like that. But, whenever I see my patients, they're coming out of outpatient or they're coming to inpatient, they tell me, they're like, yeah, like I'm not able to transfer anymore because of this X, Y, and Z. And it's just like, so much of this has to do with the environmental challenges and barriers, and all of that has to do with systemic racism and injustices. And, there's a lot of higher level stuff going on, but I'll kind of end there because I can ramble about this forever.
Oh, that was great. Thank you so much, Dolly. And yeah, we have to care about this because it's important to recognize because it's impacting our clients and their outcomes. It's impacting their recovery. It's impacting just even if they get sick in the first place, or the different neurological disorders that we see. Because we also have to see that's where, for example, if you look at Alzheimer's, this is another one where if you look at the social determinants of health and things like that, you're going to see, again, I believe African Americans overrepresented in the diagnosis. And so we have to care about neurofunction and the impact of injustice, because this is how our clients and our patients and we ourselves, if we identify as any of these populations, this is how we're getting ill. And I love the answers in the chat. Thank you, everyone, to give us deeper understanding, for us to be able to advocate. Heck yeah, Madeline, love that. For patient education. And Lauren saying that OTs were responsible to be advocates and active change makers in addressing occupational injustice, inequity, racism, sexism, you know it. I love that. Thank you, Lauren. So my next question is, what can we do as occupational therapists to address injustice? Yes, Tamika.
Can you hear me?
Yep.
Okay. I don't know. So I graduated from the UWM's program maybe 13 years ago or something like that. And so I practiced a little bit, and I feel like the most impact, obviously we need our practitioners, but one thing that's been really helpful for me, and I personally had the pleasure of working with Dr. Shalaru. This is an awesome presentation, so thank you. Dr. Tony Shalaru, I'm sorry, I know there are two on this call, runs in a family. But I think for me, it's been really enriching to be even on the academic side of it, where somebody like on a systemic, I want to call it a systemic level, as far as like having somebody come in. Dr. Shalaru is actually revamping our curriculum along with our students from Diverse OT, really trying to address some of the systemic issues on the program level as far as teaching this type of information. And I think I say that because I'm a little jealous of the students now, because I think 13 years ago, I never had a presentation like this. I didn't have access to a professor like this. So I think a lot of it is awareness and really trying to educate the future of occupational therapy students as far as building this awareness and making sure they have this information when you go out and you are acting as advocates for change.
Awesome. Thank you, Tamika. I love the answer. And honestly, you really could do the back half of this presentation for me. So thank you. And and the one last question before I move on, just for the sake of time, what are our moral or ethical obligations do we have as healthcare practitioners to address injustice? Yes, Valencia.
Let me unmute. Hi. So I feel like we do have a significant obligation. We can't say we care about the clients we serve if we don't care about the injustices that they face. And there's a lot of depth to the injustice. So just tackling it one step at a time. I can go so deep into this, but I'm gonna cut it short for time's sake. Discussion afterwards, right? Just relying on other professionals or just seeking out the resources that they need, starting somewhere rather than nowhere, taking action. It all makes all the more difference. It's like for me personally, I can't just hear something and not do something about it. It's just like, whoa, it's a lot, but just let me process it. Let me go find something. There has to be something for somewhere out there. There has to be a way to acquire that resource.
Absolutely. Thank you, Valencia. And I really loved what you said. If we claim to care about our clients and their outcomes, then we have to care about the systemic injustices that they're facing. Tattoo that onto my soul, put that on a t-shirt, I will wear it. That's exactly correct. So especially look at things on a systems level. So even at a governmental level, with access to abortion care, access to hormone therapy for trans people, looking at Medicaid being slowly chipped away at. These are all things that we have to pay attention to, because it is impacting our patients, our clients, and some of these things that are happening at a systems level violate the ethical principles that we claim to have as OTs. And yes, if we don't as practitioners, you're always attending to the symptoms, not the root cause or disease. Exactly. We have to get to the root cause of these issues, and that's what addressing systems does. So with this last bit of time, I wanted to talk about the participatory occupational justice framework. So this framework is used to be able to apply and act on engaging with, understanding injustice, and then intervening as OT practitioners, because we do have that ethical responsibility. We do have that moral responsibility to look and help others, to be in solidarity with one another, and to take care of our fellow person on this planet. It's up to all of us to care about one another, and I'm going to show you how. So here are the 6 points of the participational occupational justice framework. It is intentionally designed as a circle because it is a nonlinear process. It is supposed to serve as a blueprint for action, for taking action against occupational injustices. So here I've taken each action point and broken it down into some things that we can be doing. So the first is raise consciousness of occupational injustice. Things that we can do that I saw some people say down in the chat. We can intentionally seek out learning opportunities about occupational and social injustice. And I'd like to say my big thing that I like to say before you start attempting to go out and save the whole world, the best place you can actually start is with yourself. You have to take a good, hard look at yourself. Ask yourself some reflection questions, and you also need to understand your own positionality within the system, right? So am I a person who benefits from the system? Am I a white, able-bodied, heterosexual, upper middle class person? Like, how do I position within this system? And that's not to say all of those identities, that you don't have any identities that are on the negative side of, or that are treated negatively by these systems, but to explore what your identities are and how it impacts you, because you will have identities that do privilege you, and then you may have identities that are seen as a disadvantage by society. Also, throughout this, I won't go in depth because of time, but anywhere you see the bullet point that says C, who am I and what do I bring into clinical practice? For every suggestion that I'm giving today, you all will receive a whole folder, a massive folder of resources after this presentation to get you started. So in the resource email that you'll be receiving, you will actually be given a social identity wheel, reflection questions, and a guide for getting you through this process. So anything I recommend, I'm not going to leave you hanging. I got an example for you, and I have it all ready to go when we're all done, because change is possible, and that makes me excited. Other things that you could do, some really simple things we can be doing. Diversify your social media follows. Are you following disabled people, people of color, Black people, activists, LGBTQ plus people? Those are all ways to, and mind you, please search responsibly. Not every Instagrammer is doing the work, but these are all easy ways to start diversifying the information that you're receiving and understanding and learning about new people. You also have to be intentional about wanting to learn. So creating goals for learning. So I have a little goal sheet that I make, and this year my goal is to learn more about these struggles of Israel and Palestine. I'm not really well versed, so I have to make it an intentional goal to learn about this. And last but not least, please read some political texts. I don't care if you're Republican, Democrat, Independent, whatever, however you vote, politics are impacting you as we speak. Things are happening, and you have to educate yourself on how systems work to understand how to challenge these systems. The next is to engage in collective action to bring to light occupational injustices that are happening within our own OT programs and professional bodies. Yes, Jamie, voting is very important. So our professional bodies like AOTA and AOT PAC. It's important to know our history. Where did OT come from? Where are these foundations of OT? Why are we in a place that we are still an overwhelmingly homogenous population? It's overwhelmingly white middle-class women in OT. How did we get here? Well, it wasn't by mistake. It was actually by design. So you can check out the presentation where all the Black OTs that will be sent to you, which teaches you about the history of OT and how we ended up. Also, protesting and political action is actually really good. I know there are a fair amount of people on this call today who are familiar with what's happening at USC, and they're protesting on behalf of Dr. A, who was a Black and Iranian woman who was released from her job under very dubious conditions. And I know in OT, we're very conflict averse. Oh, don't say it, don't challenge, don't. And the USC students are showing what the power of collective action. So this is a little blurb from their Instagram. You can follow them at USC Chan Justice Collective. And they're a great example of the power of collective action and students coming together to call out something that is wrong. So you as students, you all do have power. Honestly, we all have power when we work together. We also can see, we included the Diverse OT post about AOT PAC. That's another thing. For example, our AOT so far this year has donated over $150,000 to Republican candidates, which in itself, okay, I can move on with no question, because that's what AOT PAC decided to do. But then when you look into the voting records of the people that they have given money to, there are people who voted against Medicare spending, people who voted against LGBTQ health and rights, people who voted against women's health care and abortion rights. So they're donating money to candidates who are voting in ways that are against AOTA's ethical principles, right? So we have to look into these type of things, and it's okay to ask questions and to say, wait a minute, why are we doing these things? The next is to engage collaboratively with partners. So creating a partnership between faculty and students to meet the occupational needs and injustices faced by students. So just like Tamika mentioned, at UWM, we're doing a climate, culture, and curriculum redesign. And this is a joint project between our students and our faculty and our staff. Our entire community is involved in redesigning this program to meet the needs of our students. It's important that you work with your clients and ask more about the issues that they are facing and learn about the systemic issues they are facing. So this will assist you with raising the consciousness of occupational injustice. Some examples of working with your client is DiverseOT Chicago, which is no relation to DiverseOT National, but we just happen to love them. And recently they had done a campaign to raise money for unhoused individuals in their community to provide food items and other necessary items to help them with their ADLs. And also shout out to DiverseOT Chicago, follow them on Instagram. They're a Latinx-led OT collective that is doing justice work in the communities that they serve and provide opportunities for education. Love them a lot. And also engaging collaboratively with partners requires power sharing, also requires collaboration and self-reflection. So what biases do I hold? What is preventing me from sharing power? And it's always, always, always important to understand that lived experiences trump our OT expertise. So when we're engaging collaboratively, these are some of the things that we could be doing. Mediate agreement on a plan. So creating an action plan for change in collaboration with the people who are impacted. So to OT programs, they should be providing action plans and timelines to change related to issues raised by their students. That's something that should be fine, or should be a norm of transparency and openness. And it also lets you hold your program accountable whether they're changing or not. OT practitioners should work with their clients to create action plans to address injustice and create action plans with the employer to promote systems level changes. And as students, you can come together to take a critical look at your programs and identify injustices that occur and offers ideas to remedy. The next is strategize resource funding. So engage in mutual aid. Mutual aid is when everyday people get together to meet each other's needs with the shared understanding that systems we live in are not meeting our needs and that we can meet them together right now without having to pressure power structures to do the right thing. Mutual aid is an idea and a practice that is based on principles of direct action, cooperation, mutual understanding, and solidarity. Mutual aid is not charity, but the building and continuing of new social relations where people give what they can and get what they need outside of unjust systems of power. So an example here, shout out to our Colorado State University chapter that has started their own scholarship for underrepresented students into OT, which y'all can donate to. And they also do have a mutual aid fund that is available for students in case they're ever in need or in a tight spot. So we love to see things, and this is what is possible. We also want to support implementation and continuous evaluation. So OT programs should be looking to create standards for change that are higher than ACOT standards. Clinicians, we should be creating standards for reflection and evaluation related to justice and equity principles. And ask yourself, are these topics reflected in your end of the year evaluations? That's something that you can advocate for right now as a clinician, saying, hey, we need to really make justice something important even here in the clinic. For faculty, ask yourself, how are you engaging in self-reflection? How are you improving your courses to infuse principles of equity and justice throughout? And then for students, what are some ways you can self-reflect? And then inspire advocacy for sustainability or closure. That means creating systems that are made to thrive. And here we have to understand that the foundations of OT are built on racism, ableism, and classism. If the foundation is rotten, then you have to rebuild the whole system. So I think a lot of times when we have these big conversations, a lot of times people just want there to be that quick fix. How are we going to fix this system overnight, especially in academic settings? And the answer is we can't fix it overnight. Sustainable change takes time, effort, community, and the willingness to change. So if you want to change, if you want sustaining change within your program, for students, you might have to be the one to push your faculty and staff to start recognizing this. And for faculty and staff, it's your responsibility to say, I want to make this program better. I want to make this program more equitable, and I am willing to change, share power, build community, and put in the time and effort to make this really happen, in addition to collaborating with everyone and building the community that you want. But that being said, we're doing it right now at UW in Milwaukee. So I want you to know that change is possible and that we can be taking steps right now to build a better future for all of us. And that's my presentation for today. Thank you so much, everyone, for coming. If you have any questions, I'll hang back after this. All the resources, like I said, will be sent out in an email after this presentation. And here are all the places that you can find us at DiverseOT. If you liked us, if you like this presentation, feel free to drop us a few dollars. But thank you so much, everyone. Thank you for being here. And like I said, I will hang back for any questions, comments, or considerations. Hi, Valencia.
Hi, I have a question.
Yes.
So it's based on a